I'd like to invite Dr. Dipanshan Pal to brief and very briefly introduce what this session is going to be about and then take over.
Yeah. So, good morning all, and thanks All India Ophthalmic Society to give us this wonderful opportunity. So our IC is trabeculectomy enrich your basics. As we know, the trabeculectomy has undergone revolutionary changes since its inception. Judicious augmentation with antimetabolites, selective use of porcine collagen, and various modifications of the standard procedure have ensured enhanced success with increased safety. Intensive post-operative follow-up and the low threshold for early intervention has resulted in higher proportion of eyes achieving target. This IC will offer some basic guidelines, starting with a prolific glaucoma surgeon of the East, Dr. Shubhit Chaudhary. He will tell about how do he selects his patients for trabeculectomy. Followed by Dr. Suchandar Shaw. He's a senior consultant in Disha Eye Hospital, and my colleague and a dynamic lady. He will be talking about the judicious use of mitomycin. Followed by Dr. Moiri Khamar, who is one of the prolific glaucoma surgeons of the West, recipient of the prestigious D.V. Chandra Award for glaucoma. Madam will tell about how to get a favorable filter. Then Dr. Partho Mondal, he is also my colleague, a senior glaucoma surgeon, and heads our Durgapur unit. Will tell about if the baby is born, how to nurture it. And Dr. Sharbila will join us from Arvinda Hospital, Madurai. She's a senior consultant, a very good friend of ours. We tell about treating the ailing babe. And last but not the least, our Secretary, Glaucoma Society of India, Dr. Chandrima Paul, we will tell when to prefer porcine collagen and ologen in traps. And at last, I will talk about if supplement injection offers a better choice. And we are very delighted to announce that we have a keynote speaker from USA, Dr. Arvind Nilakantan, who specializes in medical and surgical management of complex glaucoma and cataract surgery, received his medical degree from University of Bombay. And he has then completed 3 residencies in Bombay, in University of Glasgow, and then in University of Florida, and done his clinical fellowship in glaucoma at prestigious world-renowned institutes like Shankara Nethralaya, Chennai, Moorfields Eye Hospital, London, and Bascom Palmer Eye Institute, Miami, Florida. In addition, he spent 2 years of glaucoma research fellow at University of Florida, Gainesville, and awarded a National Institute grant for his work on wound healing and glaucoma surgery. Continues to actively pursue his research interest, which includes developing newer and safer minimally invasive surgical techniques to treat glaucoma. I would like to invite him to give his talk on tube versus trabeculectomy. Dr. Arvind, are you there?
I'm here. Thank you so much for the wonderful introduction. Thank you, Dipanshan and Amit, for this lovely. It's 1 o'clock in the morning, but I'm awake.
Wow.
Also,
yeah. You have always been so dynamic. Like to see you, Arvind.
You know, my glaucoma career started at Shankara Nethralaya. So the previous session was very emotional for me because a lot of my teachers were in there, and obviously I imbibed a lot of Dr. Badrinath's principles in my practice. And my 2 mentors, Dr. Vijay and Dr. Rao, unfortunately, Dr. Rao passed away this last year and he's not with us anymore. You know, and they've been very instrumental in guiding me through my glaucoma career. So I'm always willing to give back, and I really appreciate the opportunity to present. I may look a little dreamy-eyed because it's 1 a.m. in the morning, but hey, it's Friday night, you know, it's the weekend, so I'm happy to be here. I'm going to try and share my screen. So I hope I can share my screen, and that's there.
Definitely.
I think that's the way it goes. Okay, all right. So that's my screen, and I'm going to go on here. So Amit said very specifically that I should stick with 10 minutes of TVT trial and really nothing else. So I'm going to just present purely on the TVT trial. I'm not going to give you any of my biases or any of my own surgical issues. I have no financial disclosures related to this presentation. So, currently available glaucoma drainage implants in the community can be divided into non-valved implants and valved implants. And essentially, we're going to be talking about non-valved implants because that's what the TVT study used. So there's a great concern when the TVT study was conceived at about, the conception started about 2005, 2006. And there was a concern that we were seeing long-term complications of mitomycin use in trabeculectomy. And it's very interesting that you put my talk at the beginning of a trabeculectomy symposium. I think over the years, we have learned how to use mitomycin better. But way back in the early 2000s, we saw a lot of endophthalmitis, and there was a lot of problems with Blebs and Bleb morphology. So tube shunts seemed to offer a better surgical approach, and nobody really knew what was the preferred alternative, especially in patients who had already failed trabeculectomy. So if we looked at practice patterns in the United States comparing from 1996 to 2002, there was definitely an increase in tube shunts over trabeculectomies over a period of time. So at the Bascom Palmer Eye Institute, they set up this multi-center randomized clinical trial at various clinical sites across the United States to compare the safety and efficacy of non-valve tube shunt surgery to trabeculectomy with mitomycin C in patients with previous ocular surgery. So again, I will stress these are patients who had either failed a previous trabeculectomy with or without mitomycin or 5-FU, or had undergone cataract surgery. Even clear corneal cataract surgery with no conjunctival involvement patients were enrolled in the study. Inclusion criteria included patients with the age of 18 to 85. The intraocular pressure had to be greater than or equal to 18 millimeters of mercury or less than or equal to 40 millimeters of mercury. Again, we talked about how previous cataract extraction with IOL implantation failed a trabeculectomy or both procedures. Exclusion criteria, obviously we're unwilling to get consent, pregnancy, if the patient was blind. All secondary glaucomas were excluded. If there was posterior blepharitis or anywhere where you think that there's a risk for endophthalmitis with trabeculectomy, they were excluded as well. Again, if the patient was aphakic, there was vitreous in the AC, or he thought there was a need for a combined procedure with the cataract surgery or any other procedures, or a patient had previous conjunctival scarring like a buckle from retinal detachment surgery or something, they had to be excluded from the study. Two treatment groups. Exclusively 350 millimeter square barrel glaucoma drainage tube implants we used. Now in India, you have the aqueous, the Aurolab aqueous drainage implant available, the RD implant, which is similar 350, so you can use a correlation towards that. All tube implants were placed in the supratemporal quadrant, and there was flow restriction to the non-valve implants. The choice of flow restriction was left to the individual surgeon. So could I just be a vicral tie, or could be an obturator within the tube or along with the vicral tie? As far as trabeculectomy goes, all trabeculectomies were performed in the superior conjunctiva. The dosage of mitomycin used was 0.4 milligram per mil for total duration of 4 minutes. Pretty excessive in today's day, but that's what people were using way back when the study was conceived. Outcome measures were intraocular pressure, visual acuity, fields, quality of life, reoperations, complications, and need for supplemental medical therapy. Failure was defined as an intraocular pressure of greater than 21 millimeters of mercury, or not reduced by 20% below baseline on 2 consecutive visits after 3 months. If the intraocular pressure was less than or equal to 5 millimeters of mercury on 2 consecutive visits after 3 months, it was also considered a failure. Any additional glaucoma surgery or loss of light perception vision is also considered a failure. Success was defined as complete and qualified, depending on whether there was need for supplemental medical therapy. The demographic characteristics were pretty similar between both groups. They enrolled 107 patients in the tube group and 105 patients in the trabeculectomy group. Average age was somewhere around 70 years. There was predominantly a female to male gender, and most patients there was a good mix of white and black patients between the two. And just that you know, black patients have an increased risk of keloid formation and scar tissue formation. So I think it's really important that you have a good proportion of black patients within the study. The baseline ocular characteristics, they started with an intraocular pressure of mean of about 25 millimeters in both groups. Both groups were a mean of about 3.3 medications, predominantly primary open glaucoma. And these were all advanced glaucoma patients with a mean deviation of nearly -15 or -16 in both groups. So these are not early glaucomas, these are not moderate glaucomas, these are pretty advanced and significant glaucoma patients. So they randomized 212 patients into a tube and trabeculectomy, 107 in the tube group, 105 in the trabeculectomy group. At the end of 5 years, 69 patients completed the study in the tube group and 76 completed in the trabeculectomy group. 14 patients died in each group, and some missed follow-up visits along the way. So if you look at the treatment outcomes per se, looking at each year, starting at baseline, year 1, year 2, year 3, and year 4. So at the year 1 study, which they actually published, both groups actually achieved low teens, about 12.5 to 12.7, using an average of about half medicine and trabeculectomy and about 1.3 in the tube group. And when you go down to 5 years, the tube group was sitting at 14.4 millimeters of mercury, the trabeculectomy group at 12.6, and mean glaucoma medications of about 1.5 in both groups. So if you look at the intraocular pressure over the year, like I said, both started off over 25, and then if you went down at about a year, they were pretty similar at the end of 1 year. But now if you look at the end of 5 years, there seems to be a divergence. That, you know, there was a divergence in that the trabeculectomy group was slightly lower and the tube group was slightly higher in terms of trabeculectomy, but in terms of clinical significance, there was no clinical significance between the two groups. The probability of failure at 1 year was 13.5% in the trabeculectomy group and only 3.9% in the tube group. But if you extend that to 5 years, in the tube group, the failure rate is about 30%, whereas in the trabeculectomy group, the failure rate rises up to about 50%. The number of complete successes is pretty similar in the tube and trabeculectomy group, whereas qualified success is a little bit higher in the tube group. There's no statistically significant difference between the failure rates in the tube as well as the trabeculectomy group. So what are the reasons most treatments fail? Most patients fail because of inadequate intraocular pressure reduction in both groups. There was also reoperation for glaucoma in about 7 patients in the tube group and 11 patients in the trabeculectomy group. Persistent hypotony seemed to be a problem more in trabeculectomy rather than the tube group. Now, when they went back and reanalyzed the data, there was clinical hypotony, or we call just numerical hypotony, where the pressure was below 5, so they classified it as a failure, but the patients retained good visual acuity and retained visual field over a period of time. And there were very few patients in either group that actually lost vision. There was loss of light perception in 1 patient in the tube group and 1 in the trabeculectomy group. So if you were to use stricter definitions of success, that is, if you failed with a pressure over 17 or failed with a pressure of 14, especially given that these are advanced glaucoma patients, you know, the numbers change again. In the failure rate rises to about 53% of the trabeculectomy group for over 17 millimeters of mercury and rises up to about 32% in the tube group. Whereas if you go to the greater than equal to 14 millimeters of mercury, you can see that, again, there's a staggering and the failure rate increases. So what are the reoperations for glaucoma in the tube in both groups? So if you already had a tube put in, 4 patients had another tube put in. The other 4 had transcranial cyclophotocoagulation or a diode cyclophotocoagulation. 1 patient underwent an EC-pre, and eventually this ECP patient also underwent a transcranial diode cyclophotocoagulation. Patients who failed trabeculectomy, 15 of them underwent a tube shunt, 1 underwent a CPC, 2 of them underwent a Bleb revision, and 1 had a trabeculectomy with 5 FU. Again, if you look at the total cumulative percentage of patients who had a reoperation, it's about 9 and 29. So the numbers are higher, 8% and 18% between the 2 groups. Again, not statistically significant. Early postoperative complications less than 1 month, again, pretty higher, much higher in the trabeculectomy group, given there were more choroidal and shallow anterior chambers. There was some wound leaks also included, but again, it was a little slightly statistically significant at that point. In terms of late postoperative complications, pretty similar between the 2 groups, but I'd like to point out a few ones here. One is diplopia in the tube group. Second is tube erosions in the tube group, and that's what you got to really watch out for. Whereas in the trabeculectomy group, they're it's mostly choroidal effusions and Bleb leaks that trouble you in the long run. If you look at reoperations, again, pretty similar between the 2 groups, about 20 in the tube and 15 in the trabeculectomy group, not statistically significant. So if I were to conclude, non-valve tube shunt surgery had a higher success rate compared to trabeculectomy with mitomycin in the 5 years of follow-up. Both were associated with similar intraocular pressure reductions and use of supplemental medical therapy. Additional glaucoma surgery was needed more frequently after trabeculectomy with MMC than with valve replacement. Large number of surgical complications in both groups. The incidence of early postoperative complications was higher following trabeculectomy rather than the Barwell group, but the rate of late postoperative complications and reoperation as well as cataract extractions was similar in both groups. So to conclude, that the TVT study really does not demonstrate a clear superiority of one glaucoma surgery over the other, but really indicates that if you have a patient who has failed a trabeculectomy sitting in front of you in your office, you have two options. You can either choose to go the tube route or you could choose to go the trabeculectomy route. Your skill and expertise in dealing with these operations, as well as the patient's willingness to undergo repeat glaucoma surgery, will be an important factor in what procedure you are going to choose for that individual patient. Again, cannot stress enough that you cannot extrapolate these results to use with armored valves, because I know that in India predominantly armored valves are used, and you really cannot extrapolate these results to use of armored valves. Subsequent to this study, the primary tube versus trabeculectomy studies have been set up. Due to lack of time, I'm unable to discuss them today, but you can look into literature. The 1 and 3 year results have been published. So thank you very much for this, and I hope you got some critical pearls out of my presentation.
Many thanks, Dr. Arvind. As you have been an excellent deliberation. So without taking much time, we have decided to take the question and answer at the end of the session. I will go with our IC. I would like to call upon Dr. Sumit Chaudhary for his presentation. How do I select my patients for trabeculectomy? And I would request Dr. Arvind if you can wake up at late night to be a panelist. Thank you, sir. Shumita. Shumita, unmute yourself.
Crisis. Already. It's unmute. Can you hear?
Yes. Yes.
Yeah. Thank you, Dipanjan, for taking me in the team of the IC for the basics. And thank you, AIOC, for calling me.
Share your screen, Shumita.
Can you see it?
Yeah.
Topic was given today, how do I select my patients for trabeculectomy? This is a very tricky one in this area. But the first thing I want to say, the decision for surgery should consider the risk and the benefit ratio, because the risk the patient has to take and the doctors has to take, and the benefit the patient is to gain from the trabeculectomy. So these are the two, you have to take the decision, which one is better for the patient. So why trabeculectomy? Because it is found that the maximum medical therapy or the laser surgery fails to lower the target IOP. Everything that is a target IOP. If it fails, we can go for the next stage is the surgery. And that's the trabeculectomy. That's the gold standard still yet. Another thing I found is the irregularity and the compliance with the medicines applied. Many patients, there's a big number of patients, this compliance is there. For these patients, I try to convince them to go for the surgery. Coming to the cost is a variable now because the indigenous, the cheaper medication or the prostaglandin available. The patient pressure controls is there and the field is also maintained. The cost is not a matter. But in some cases, cost matters for some patients who cannot afford it. For those patients, I try to go for the trabeculectomy. This comes the side effects of the drugs. This is a very important, lots of side effects of the patient in each and every drug, many patients. So in these cases, it's better to go for the trabeculectomy to avoid the side effects of the drugs. At the polypharmacy, not a single drug is being used, maybe 2, 3, 4 drugs is being used. And all these are polypharmacies for the drug and also for the preservative. There is lots of side effects, dryness and other. In these cases, if the patient cannot afford it, cannot maintain the polypharmacy, we can go for the trabeculectomy. And the last thing, what I want to say that first you have to understand the disease. Make the patient understand, make the patient and the party understand the disease before going for the surgery. So they have to understand what the glaucoma is. Next is the progression of the glaucoma. Progression is the main treatment is the quality of life has to be bettered. If you find any that compromise, so we have to turn for the trabeculectomy. And even if you find the structural and the functional changes is there, in spite of the pressure is standard with the medicine, sometimes I go for the trabeculectomy. Because the stages of the disease, what the stages is the moderate, mild, moderate, or the advanced. If the patient is in advanced stage and the patient has lots of complications, the senior is also comorbidities and they cannot afford it or something else of that. In these types of cases, I sometimes go for the trabeculectomy. Even in the early younger patient with the advanced stages, I prefer to go for the trabeculectomy because it gives a more standardized, except the complications. Age of the patient, what I was talking, the patient at the younger age for the long life has to be taken, or the young old age, the shorter lifespan. This has to be taken into account before going for the trabeculectomy, because the progression is the glaucoma. Once it occurs, sometimes it's very difficult to stop it with the drugs. So maybe trabeculectomy helps. And how rapid it is progressing. In some cases, in low-tension glaucoma, normal-tension glaucoma, the rapidity of the, even if the patient is low teeth, you can go for the trabeculectomy. In the left side, because this is a field testing, it started in 2014. Still in the 2020, it looked the standard. There's a rate of progression. It hasn't deteriorated or slight changes in that. In these cases, no, wait. But in the right side, if I go, it was a pre-operative, is it January, the March date. After that, I did go for that trabeculectomy, which is a one-eye patient with this small field of vision, is the irregular medication. And to my surprise, after 3 months, when I did the field testing, the field increased. It may be due to the learning curve. I don't know. But in this case, you have to take the risk and benefit for the patient. We have already wanted the target of one eye, but you have to look for the other eye, because sometimes we miss the other eye for the progression. So what stage of the patient is going on to the other eye is also look for before I try for the doing for the trabeculectomy. And the family history of blindness has to be taken care of. And primary surgery is still debatable. In my cases, in some patient, if I can go for the counseling, if I found the patient and the party not listening or not understanding the type of disease, and for the long run, they won't come for the follow-on, I try to convince them for the surgery. Maybe I'm taking the risk and benefit of the patient. Thank you.
Thank you, Shumita. Just excellent talk, and you just finished within 5 minutes. And our next speaker will be Dr. Suchanda Shaw. She will talk about how to be judicious with mitomycin C application in travel. Suchanda, are you there?
Yes.
Yeah.
Can you see my screen?
Yes, yes.
Thank you. Good morning, everybody. Thank you, Dipanjan. It's indeed a privilege to be a part of this IC. Mitomycin C has been used extensively over the years as the antifibrotic adjunct with glaucoma filtration surgery. But in spite of that, till date, we really need to be judicious with mitomycin C, because we are yet to find out that optical dose delivery protocol which will give us maximum therapeutic benefit with no serious complications like scleral thinning, very thin blebs with potential of leaking, hypotony. Today, mitomycin C is maximally applied with the help of soap sponges over the intended area of filtration site.
Can you make it full screen, Suchanda?
Full screen?
Full screen.
Yes?
Yeah, thank you.
So studies as early as 1998, studies have been done to show the delivery of the drug in fluid delivery system was done with the help of Vexel sponges, and dry filter paper was used, partially hydrated, sometimes dry, to simulate episcleral tissue. And they showed that the maximum delivery of the drug was done within the first 15 to 30 seconds, and then it gradually plateaued over around 3 minutes. But if the sponges were changed at every 1 minute, then the delivery system, the delivery was much higher than if it was done with one single sponge. The hydration of the filter paper also made a difference to the amount of drug delivery. Further studies have also shown, and now it has been, the norm is to apply mitomycin C from 1 to 3 minutes, depending upon the patient, depending upon the surgeon. But it has been seen that application of mitomycin C beyond 3 minutes does not give any significant therapeutic benefit. Now, once the mitomycin C has been applied, what is the actual amount that is delivered? Sponge delivery variables, tissue levels with 5-fluorouracil was studied by Mark R. Williams, and they used porcine eyes where they applied the drug at 2 and also studied 1 and 3. So 3 areas were studied from porcine eyes, the sclera and the conjunctival levels of the blood of the drug after delivery. What they showed was they used 2 sizes of sponge, 7x4 and 3.5x2, but they showed that in the conjunctiva and in the sclera, there was no significant difference of the drug level in spite of using sponges of different sizes. But what they showed was that the material of sponge made a difference in their study. The Wexel and Merocel sponges, which we commonly use here, more or less delivered the same amount of drug in the same time, whereas the ultimate sponges that they used delivered more than twice the amount of drug within the same time. So material of the sponge along with duration of exposure were 2 variables that were seen to play a role in drug delivery. But what was interesting is that this biopsy, conjunctival biopsy over the application of the sponge area showed that the smaller sponge delivered more localized, higher range of drug in the conjunctiva rather than the larger sponge. And that is what is seen, that it is better to apply multiple sponges for a diffuse larger area of exposure rather than a large single sponge, which may lead to more chances of a mitomycin C burn. Another study where they studied sponges using PVA, that is polyvinyl alcohol, polyvinyl fluid wicks, and gelatin sponges, they showed that in these 3 materials, they did not see a significant difference in the percentage of MMC that was delivered to the tissue within a given time. And they also showed that the maximum delivery in spite of the material happened and plateaued at around 3 minutes. Now, what about the irrigation, which is another variable regarding the use of MMC? How much irrigation is ideal irrigation? 15 ml, 20 ml, 100 ml, 250 ml, as different studies have come up with. But now what we commonly follow is the recommendation by the Moorfield Safer Surgery System that at least 20 ml of PSS should be used to irrigate immediately after the sponge removal. Susan J. Lee et al., they came up with an original research paper where they came up with an MMC titration protocol. They observed their patients pre-operatively and gave them points. For example, 1 point was given to patients less than 40 years, black race, PCIL, virgin conjunctiva, 2 points to less than 25 years, PCIL with conjunctival scar, ACIL, no vitreous. And in this way, they gave their patients points and then used this chart to titrate what would be the approximate concentration of mitomycin to be used in that patient and what should be the ideal duration. Now, in spite of that, we end up with these worrisome blebs because we have realized that these variables are the concentration of drug that is delivered, the duration of delivery, the vehicle that is used, the position of the vehicle, the tenon's thickness, and the patient's receptor response. So in spite of that, we tend to get these hazardous, dangerous blebs, which gives us many sleepless nights. To overcome this, the newer trend has been to inject antimetabolite mitomycin C intratenon. The dose that is followed is 10 milligrams or 20 milligrams according to the surgeon choice. And Dr. I.K. Ahmed, who is a major proponent of this technique, has been doing it for 10 years plus and says that it has the benefit of being able to deliver the exact amount of MMC that we want. We can give a consistent dosing, and we can cover a wider and more diffuse area as this ICG stained, ICG mixed mitomycin C gives us. So the current antifibrotics that we use are the steroids, NSAIDs, 5-FU, most commonly, anti-VEGFs in some cases, but are helping us to modify our wound healing. But we are looking forward to the more promising elements, the growth factor beta family, the matrix metalloprotein inhibitors, to give us maybe more promising drugs in the future. Thank you.
Excellent talk, Dr. Suchanda. So to start with, from Dr. Shubhit Choudhury, we got an idea that we should go for trabeculectomy when we detect progression, and then when we get excessive rate of progression, and depends on life expectancy, and then Dr. Suchanda gave us a nice idea about how to use mitomycin C. Judiciously touched upon also a point of subtenal use of mitomycin C. And now I would like to invite Dr. Mayuri Kama, and she will give us tips and tricks of how does she get beautiful filters. She is an excellent surgeon. Welcome, madam.
Thank you. In next few minutes, I will try to cover how do I get favorable filter. Mitomycin is discussed so nicely by Dr. Suchita. So we know that we are working with double aims. One, the scleral flap should be very loose or loose enough to permit the aqueous humor outflow to get the good filter, but should be tight enough to prevent post-operatively hypotony, antechamber shallowing, or choroidal detachment. So the options are many for the post-operative titration of the trabeculectomy. Bleb, either you can use releasable or adjustable sutures, laser suture laces, or the digital massage, which gives only the transient lowering of the intraocular pressure, and it is challenging to the patient. And the laser suture lysis, sometimes is visualization of the suture is difficult with the thick tenons, and there is a potential for the conjunctival buttonholing, and one should have the access to the laser machine and the lens. So the releasable suture allows relatively tight closure of the scleral flap immediately, intraoperatively, and reduce the early post-operative complication, and can be moved to increase the filtration in smaller increments. So the indication for me is I use this as a routine in all my patients, and number of releasable suture depends on surgeon's choice. But for triangle flap, the apical releasable is a good idea. While with the rectangular flaps, you can have it on both the sides. These are the photographs to show you. You can start from the corneal side or the scleral side. So first take the partial thickness corneal suture, then come in the center, take the partial thickness cornea and the flap, and then full thickness of the flap as well as partial thickness of the sclera. Once the sutures are being passed, then you have to have a sleep note. Now this is how we do this. The first, sorry for this. I'm sorry.
The video is not functioning, madam.
Just hold on.
Ma'am, any problem you are facing?
The video stop in between.
Okay, so you have to reshare again, ma'am.
I have restarted.
Yeah.
So the corneal suture is to be taken partial thickness, 2 millimeter inside the limbus. You may take the two side sutures before taking the apical, or straight away you can go with the suture.
Ma'am, sorry to interrupt you. We are not able to see your screen, ma'am.
You are unable to see?
Yeah.
Oh.
You can stop sharing and sharing again.
This is what I am always afraid of, Dipanjal. Always. Okay, I will show my video straight from here. Now, can you see this?
Yeah,
yes,
yeah.
yes.
Okay, that would be better. So this is how we pass it. Then when you come in the center, take the partial thickness cornea and the flap partial thickness.
We can see the video.
That's okay. And then once you have passed it, 3 throws or 4 throws and make a loop. This is a sleep knot. Tighten it. Once it has been tightened, recheck whether you can release it or not. Retighten it. And now trim the, again I am checking from outside. And then retighten and trim it here. Once it has been trimmed, finish the rest of the surgery. I take 2 side sutures and the mattress, and the BSS is injected from the paracentesis opening. You can see the black coming up here, and then trim the outer suture. Sometimes what happens with the formation of the chamber, the suture retracts inside and it comes out and gives you Winville Viper syndrome in the end. So this is what is wind releasable suture about. Now how to remove this suture? Can you see?
Can't see, madam.
Ma'am, actually it is running in your taskbar, so you have to select the VLC option in your taskbar, ma'am.
Put your taskbar sales. There is a VLC option.
You can see the video, no? How I release and then indent on the side with the board or at the time is over. Dipanjal, should I stop?
Oh, no, continue.
Or can you give me 2 minutes?
Yeah.
Continue, ma'am.
I will not show the releasable suture. It's okay. Let us forget about this.
Unfortunately, we couldn't see it, madam. Doesn't matter. There will be some other session we will see it.
Okay, it's okay. It's okay. Should I stop sharing now?
You can stop sharing now.
Let's stop.
Okay. Unfortunately, we could not see her
But
videos.
I have shown you the technique of how to do it.
Yes. We could actually appreciate from your photographs. It was easy to appreciate from your photographs.
Yeah. Thank you.
Yeah. And our next speaker will be Dr. Partho Mondal, who will talk about how to nurture a blade that you have recently created. Parthuda, are you there?
Yeah.
Yeah.
Can you see my slides?
Yeah, I can see your slides. Please start.
Yeah. Good afternoon, respected viewers. My job is to nurture the baby. That's what Dipanjan gave me. Actually, at the outset, I would like to thank Dipanjan and at the same time, the AIOS Scientific Committee for giving me this opportunity. As a glaucoma surgeon, you all know that it's not the end of the game when you just finish trabeculectomy, because after that the another game starts. That's why Dipanjan gave me that your baby is born, now you nurture it. But the most challenging thing is to convert a failing blade into a successful blade. And that is why the nurture the blade, that means guiding the blade to be healthy and functional. Literally, failing blade means assuming the blade would fail if we do not take or any intervention out of our conventional taking care of the blade. Usually, the failing blade appearance is like it's a localized blade, it's vascular, with raised intraocular pressure, and sometimes with gonioscopy, you can find there is blocked ostium. The obstruction of the aqueous outflow may be in different sites. Near the inner ostium, it may be due to the tight scleral flap or due to episcleral fibrosis. So everywhere you have some options to manipulate the blade. If it is tight scleral flap, you can manipulate in the way like you can give digital massage, you can release the suture, or even if these two won't work, then you can do the suture lysis with argon laser. If there is any block in the internal ostium, you can do laser internal revision of the ostium. If there is fibrosis of the episcleral tissue, you can do blade needling or internal blade revision. Failing blade, usually due to you can see the high intraocular pressure with unsatisfactory blade, but in one sense you should differentiate encapsulated blade, because this is a localized high tense with vascularization, and it should be differentiated from the failing blade, because with management the encapsulated blade may be functional, and you need to decrease the aqueous production rather than increase the aqueous outflow. The telltale sign of encapsulated blade is the compression and decompression. If you just compress the lead over the blade, then it decompresses, and if you release it, again it's getting filled up. Approximately 90% achieve intraocular pressure control with medications, and medical management is aqueous suppression, as I told you, and the surgical management sometimes is needed due to the blade needling with incision onto the fibrous wall. At the edge of the scleral flap, like if the scleral flap is tight, you can do digital massage. It can be through the lower eyelid, or it can be through the upper eyelid. Even if it doesn't work, then you can release the suture. Followed by, if necessary, digital massage. Or you can do suturolysis if even after digital massage and the suture release, the blade is not functional. If there is any block in the internal ostium, with the help of gonioscope, you can do internal ostium revision with the lasers. Like here, the iris is adherent to the internal ostium, and we can release it. This is YAG laser, lysis of the closure. I'm sorry, Dipanjan, I'll take more time, I think. I'm sorry. And this is if you get any fibrosis at the early stage, you can put some laser in the ostium. This is the IAG synechulisis. You can see the iris was picked and it was blocking the ostium, and here it is released. If there is an episcleral tissue fibrosis, you can do the bleb needling.
I think particularly the late wave manipulations will be taken care by Shamila.
Right now, I'm doing internal blade revision. If you allow me, I'll just
Yes, please.
maybe 2
Please
minutes.
do that. Please.
This is internal blade revision. I'm giving subtenal injections before doing the revision. This is away from blade. Just locating the site of ostium.
And you use a Bain 26 days needle.
So even after nurturing, it doesn't work. Sharmila will take care, I think. Thank you very much for your patience here.
Fantastic videos, part to the as always, and specifically this internal blade revision, I love to do it. But I think it is useful in relatively early cases. And we like to invite Dr. Sharmila from Abhidhan Padre, how to treat an ailing blade. Sharmila?
Yes, Dipanjan.
Yeah.
I hope I'm audible.
Yes,
thank you,
absolutely.
USC, and thank you, Dipanjan, for the opportunity. So I think I'm actually going to be overlapping most of what Dr. Pata has already discussed. I'll try to skip all those which he has already covered and then just do the part which is not covered. Anyway, the topic given to me is treating an ailing bleb. So we all know what is an ailing bleb, a flat bleb, which is vascularized, there's no microcyst, and there is a high intraocular pressure. So when and why do blebs fail? They can fail either early or late. It's basically because of a vigorous healing response of the host. Most importantly, it is a subconjunctival fibrosis. There are several reasons for failure. It could be because of long-term use of anti-glaucoma medications itself or a pre-existing inflamed eyes. Surgical complications like blockage of the ostium could also be reasons for failure, and late complications like tenon cyst or extensive fibrosis are other reasons for failure. So there are several rescue measures. Most important thing is we'll have to identify what is the cause and also take an immediate aggressive action. So immediate aggressive action is in the form of stepping up of steroids, the digital massage, laser suturolysis, and eventually probably we'll need a bleb needling or a subconjunctival antimetabolites or a repeat surgery. So early filtering blebs, most importantly, it's because of episcleral fibrosis, or it could be because of something blocking the ostium. And this, of course, Dr. Pata has mentioned ocular massage. So I'm not showing this video again. And then after the ocular massage, if still there is a continuous no response in the intraocular pressure, then we may have to go for suturolysis. For those who have access to a laser machine, you can put a fixed suture and go for suturolysis. Other alternative could be to use a releasable suture, which Dr. Mayuri Kamar was trying to demonstrate. So that would be useful for those clinicians who do not have an access to a laser machine. So the other reasons could be because of something blocking the ostium. It could be just an iris, it could be a blood clot, it could be a fibrin membrane, imperforate decimates, vitreous, several reasons. So whenever there is something plugging onto the ostium, then the pupil will be peaked. So that is itself is a sign that some iris is blocking at the ostium. So first we'll use pilocarpine to allow it to constrict, and then we make a side port and use a spatula and clear out the iris from the ostium, like how it was shown in this video. So bleb needling, when, where, and how do we do bleb needling? The main prerequisite for doing a needling procedure is we should ensure that the ostium is patent. It can happen as early as weeks, and also it can happen very late as well. So exact identification of the nature of the fibrosis. It could be a subconjunctival fibrosis where we have to just target the subconjunctival area, which causes a little manipulation under the conjunctiva and elevate the bleb, or a subscleral where we may have to, there may be a subscleral fibrosis where there is a sclera which is adherent to the bed. So because of this, you may have to go under the scleral flap and release the adhesion. Sometimes we may even have to open the ostium, which is covered by some fibrous tissue, so enter it into the anterior chamber. So there are several ways of doing a needling. The success of needling has been reported to be around 50 to 75% at the end of 1 year and 31 to 52% at the end of 3 years. However, we do have some complications with needling. The most common ones are the hypotony because of sudden gush of aqueous once the ostium is patent. The bleb leaks can also happen because of inadvertent handling of the subconjunctival tissue, causes perforation of the conjunctiva. There can be hyphema. There can be also subconjunctival hemorrhages. So the late failed blebs are mostly because of episcleral or subconjunctival fibrosis, and this probably will have to be handled by needling procedures, which again Dr. Pata has shown a needling procedure. So they can happen like two different types of needling. One is the external revision. Here we can see that the first anesthetic agent is injected to balloon the conjunctiva, and then you use a 26 gauge needle which is loaded with viscoelastic and make to and fro movements to just excise the fibrous tissue which is beneath. So once you do that, it's a gritty feeling and you know that you're cutting into something. So once that is done, you can see that there is an elevation of the bleb because of the flow of aqueous. So then you inject a viscoelastic, and just posterior to this, you have to inject an antimetabolite like either a 5-FU or a mitomycin C. And then we have even internal revisions of the bleb, and then so this is like you're going under the scleral flap, and you can see the needle being entered into the anterior chamber. So this is another way of doing it, either subconjunctivally or subsclerally, and entering into the chamber. So this is a patient who had ologen. So you can see that the ologen is there, and then there are times we may have to go through the ologen and then do a needling. Because of want of time, I'm skipping this. So Dr. Dipanjan will be discussing about mitomycin and the advantage of that in needling. So then internal revision, again, Dr. Pata has already demonstrated, but there is another way of doing it. He used a needle to enter it. And here we can see that a cyclodialysis spatula is also very useful to do this. So first you inject viscoelastics once you enter into the anterior chamber, and then you use a cyclodialysis spatula which is a blunt spatula. So it is less traumatizing than the needle. I think if you're using a needle, maybe it is better to use an AC maintainer, especially in phakic eyes, in order to avoid any inadvertent damage to the lens capsule or the cornea because of hypotony, which may be expected during the procedure. So gently just go through the angle and then go subconjunctivally from inside out. So the same way you can do it on the other side also. In this way, you cover around 180 degrees. So the tenon cyst is also something which is very disfiguring. It usually happens late, and you can have to do an excision of the cyst. And then if all these does not work, then if there is continuous high intraocular pressure, we may have to think of going in for trabeculectomy with a high dose mitomycin. This is one of my articles which was published in the Indian Journal of Ophthalmology. We had evaluated 38 eyes of patients who underwent repeat trabeculectomy, and we found that a high dose of mitomycin and altering the exposure time really helped in increasing the success. So the take-home message here would be a careful identification of the signs of failure is very important post-operatively. Early intervention improves the survival of the bleb. Frequent follow-ups are mandatory in the early post-operative period, especially where most of the fibrosis or healing process happen. Primary surgery, if it fails, bleb needling can be done with antimetabolites, which improves the success by 60%. However, post-needling failures will definitely need a repeat trabeculectomy or a tube surgery. Thank you for patient hearing.
Excellent deliberation, both Partha Mondal and Dr. Sharmila, for your excellent presentations on blade manipulation, and will definitely help the viewers. And now I would like to invite Dr. Chodrima Paul for her presentation on when to use porcine collagen or ologen. Chodrima, are you there with the slides?
Yeah. Yes, Dipanjan. Good afternoon, everybody, and thank you very much, Dipanjan, for making me a part of your course. I take your permission to leave after my talk, as I am in the outpatient. So when to prefer ologen? So trabeculectomy does remain the gold standard for surgical management of glaucoma, and surgical techniques have developed over the years. And mitomycin C, you've heard Dr. Suchandra presented that very well, was applied as an antimetabolite during trabeculectomy. And however, with mitomycin C, we do see some adverse effects like vascular filtering, Blebs, cataract formation, and thinning of the conjunctiva. So focus is always on to develop less toxic agents and implants to inhibit cicatrization without adverse effects. And there comes in the ologen implant, and to serve as a placeholder and prevent conjunctival scleral adhesions. So that's the ologen on your left that you can see, and that is the microscopic picture. It is a disc-shaped porcelain derived biodegradable scaffold collagen matrix implant, and it is composed of more than 90% lyophilized porcine collagen and less than 10% lyophilized glycosaminoglycan, and a pore size of 10 to 300 mm. So ologen implant leads to a non-scarring wound healing with a prominent filtering bleb to enable successful surgical outcome after trabeculectomy. Ologen implant is biodegradable in 90 to 180 days or more, leaving a porous scaffold. So how the ologen works? The ologen implant induces a regenerative wound healing process. It works by guiding fibroblasts to grow through the matrix scaffold in a less random fashion, thereby preventing the fibroblasts from laying down in an organized fashion, reducing scar formation. And it acts as a reservoir as the aqueous humor is absorbed into its porous structure, and it acts as a spacer and mechanically separates the conjunctiva and the episcleral surface and prevents adhesion between them. So to just go through the surgical steps: preparation of the conjunctival flap, you make your ostium as you make, then the scleral flap is sutured. The ologen is implanted directly on top of the scleral flap, and the conjunctival flap is closed, and anterior chamber is formed. So this I'll skip through totally because Dr. Suchandra has very well presented the complications and all that of mitomycin, followed by the others as well. So the advantages of using an ologen implant: prevention of scar formation, preventing hypotony by creating a buffer system, and collagen matrix decreases the wound cicatrization contraction and promotes formation of a nearly normal subconjunctival stroma. It facilitates proper wound healing and the physiological functional bleb. No prior preparation is required and saves time in the operation theatre. It is non-teratogenic and no significant risks known. So we did a couple of studies with Ologen, and the acknowledgement is to the Aeon Astron Europe, who provided us with the Ologen. So we actually, it was a single surgeon, myself, operating on 31 eyes and into two groups of trabeculectomy with mitomycin and trabeculectomy with Ologen, 15 and 16 eyes respectively. And what we concluded was that trab with mitomycin was associated with a higher intraocular pressure lowering efficacy and a higher incidence of post-surgery hypotony and suturolysis in contrast to that of trab with Ologen. And the second study was phacotrabeculectomy, again, a total of 34 eyes, which were selected, and 18 eyes underwent phacotrabeculectomy with Ologen and 16 eyes with MMC. And here we concluded that Ologen provides similar surgical outcome in phacotrabeculectomy as compared to adjunctive MMC. It may be a new, safe, and effective alternative to MMC for combined phacoemulsification and trabeculectomy surgery. So here is a small video of the phacotrabeculectomy, which so I'll just show the flap here and the Ologen. I'll skip the phaco portion of it. So phonics-based flap, as we usually do for trabeculectomy, and generally I do a two-side phacotrabeculectomy sitting in the same place. So that's the flap made, and that's the starting of the phaco. So I'll just skip that portion of the phaco and take it forward into when I go back to the flap, and that's the measurement I'm taking to see whether I need to extend it, and it goes in freely, and all you have to do is just place it there and then suture up your conjunctiva. And so there you are, and that's it. So in conclusion, various studies demonstrated significant enhancement of success rates and post-operative IOP through intraoperative use of MMC. This was accompanied by an increase in adverse effects such as cataract formation and all that we've already spoken about. So Ologen implant will also be an adjunctive in repairing post-operative bleb leaks in human subjects. The Ologen implant was tested for augmentation in deep sclerectomy. The study revealed that deep sclerectomy with Ologen implantation is an effective and well-tolerated method for IOP reduction. This is another pilot study which was done, and I told you about it. And in summary of the previous studies, the use of Ologen implant promises comparative IOP reduction after trabeculectomy and a lower risk profile in comparison with the use of antimetabolite like MMC. So these are my references which I used. Thank you very much for your attention.
Wonderful, Chandrimati, you just spot on time.
Thank you very much, Dipanjan.
Yeah, so you will be leaving, so we'll miss you for the discussion if we have actually any time. So without spending no more things, I will just start sharing my. Yeah.
Thank you very much. Thank you very much, Dipanjan.
Thank you. Thank you. So, am I audible and visible?
Yes, sir.
Yes, yes.
Yeah, thank you. Is it the future sublingual injection of mitomycin C? So why mitomycin C injection? So we must understand that when you use sponge, there is some amount of unreliability and uncertainty about the inconsistent absorption of mitomycin C into sponge, and there is worry of leaving behind bits of it. And there may be a localization effect that Dr. Suchandra Shah also was telling. And on the other hand, if when we use injection subtenon in the subtenon space, or rather intratenon space, there is precise delivery of the desired amount of drug and no worries of leaving behind a sponge. And we can ensure a wider and uniform application of mitomycin C, and definitely the surgical time is shortened. And there is enough evidence in the literature regarding use of mitomycin C injection in blade building procedures earlier with considerable success, where mitomycin C was superior to 5-FU in practice studies, and they have ensured long-term safety. So we have a few studies on this use of intraoperative injection versus sponge applied mitomycin C. This is a 1-year study, which was basically a retrospective comparative case series of 30 eyes each, one with injection and other with sponge group. And they showed that there was significant intraocular pressure reduction at 1 year, but the group with injection had a better response, and also the proportion of eyes which needed a 5 Fourier intervention with needling were significantly lower in that injection group. In a recently completed study by Dr. Hamid Etsabiri et al. Also showed that although success rate and intraocular pressure reduction was comparable with both techniques, the Bleb morphologic parameters were more favorable after an injection of 0.1 ml or 0.01% of mitomycin C. So we also did a study. It is not actually a study. This is a non-comparative retrospective case series, kind of a pilot study on 39 eyes of 39 patients, where we did combined phaco track. We completed minimum 1-year follow-up. We included people more than 40 years of age of primary open-angle glaucoma with mild to moderate visual field damage or visual field deterioration and maximum tolerable medical therapy with cataract. Excluded these patients. And we examined BCVA, slit lamp, gold band acceleration, telemeter, gonioscopic fundus examination, automatic perimetry at the beginning of the study, and followed them up on 3 days, 1 week, 2 weeks, 1 month, post-op until 3 months, up to 1 year. All cases were done by me. We injected 20 microgram Mmc injection at the beginning of the procedure, and we made a triangular spiral flap, single apical 10 or nylon fixed suture. But the connector was closed with A2 bicril, and we did Bleb manipulation in between 3 days and 4 weeks. In follow-up examinations, we did BCVA slit lamp examination and civil test at every visit. We took intraocular pressure measurements. And
Dr. Deepanjan, please adjust your speaker.
Okay. Is it fine now? Is it better now?
Better, better.
And Blebs were graded with Indiana Bleb appearance grading scale, and complications were noted. Bleb needling for impending Bleb failure were done up to 4 weeks, and 30 minutes after injecting a 10 microgram mitomycin C into the Bleb adjacent subtenant space, a 26-gauge needle was used to dissect the subinterval adhesions in the operating room. How do we prepare this 20 microgram? We take 5 milliliter of BSS. We add 2 milligram of mitomycin C powder, 0.5 ml of the mixture. We mix with 0.5 ml of lidocaine, and around 0.1 to 0.2 ml is taken. That is, concentration becomes 0.2 milligram per ml. And the delivery per 0.1 ml, we have 20 microgram. So this video we will skip. This is a small video clip of the procedure that I do. It's around 7 millimeter from the limbus with bevel down needle. I push this 20 microgram mitomycin C and try to keep it away from the 20% stem cells and the limbus, which can cause late leaks. And after that, from the temporal side, I finish phacoemulsification. Skip that. And then I usually make a triangular scleral flap, normal trabeculectomy, and then finish it off with a single apical fixed suture with 10 or 9 nylon, finish it off with A2 bicril, and form the anterior chamber. So the success of IOP control was decided at 30% or more reduction of intraocular pressure from preoperative level, where there was no need for further glaucoma surgery or additional medication, and no loss of light perception. Bleb appearance was regarded as good Bleb with height more than equal to H2 with extent more than equal to 3 clock hours. Poor Bleb less than equal to H1 or less than extent less than 2 clock hours. Failure was defined as poor Bleb with more than 2 additional medication at 1 year, loss of LP or reoperations for glaucoma. what we saw that the mean preoperative intraocular pressure of 24 millimeter mercury was reduced to 12, and 30 eyes recorded 30% reduction, and 22 eyes recorded almost 50% reduction. And there was significant reduction of glaucoma medication at 1 year. We had good bleb morphology in almost 80% eyes, poor bleb morphology in 4 eyes, and also we got large area of avascularity that was seen in 20%, that is 8 eyes, and cystic change was observed in 2 eyes. These are some examples of cystic change, and this is Love's avascular zone like MMC burn. This is one case of subconjunctival hemorrhage. And we had treatment failure in 4 eyes with poor bleb morphology who required more than 2 additional medications to control the intraocular pressure, and early and late hypotony was associated with poor bleb appearance and eventual failure. And 1 bleb failed following late hypotony and choroidal detachment. And to discuss that, the success rate of trabeculectomy was around 77% with a failure rate of 10% at 1 year, which was consistent with results of previous studies. The surgery produced almost 50% reduction of mean intraocular pressure at 1 year, which is lower considering previous published studies. 20% of good blebs and large avascular zone, which may be attributed to inadvertent spread of mitomycin C subconjunctivally. And to conclude, the subterranean injection is a time-saving, effective, and safe alternative, and it definitely produces favorable bleb morphology and function, and large area of avascularity in significant number of patients may raise concern in long-term safety of the procedure. So thank you for your kind attention. Here we just finished our lectures, and we have no questions on board. So anybody has a question to ask to any of our speakers? Dr. Arvind, are you still there?
Sir, if we could conclude, since we are running a little late, unless there's something really important you all need to discuss.
There always be many points to discuss. There are endless points. Madam, you have any question, Dr. Mayuri, madam?
No, I have to go to the IC, so I will leave now. But
Okay. Then thanks everybody. We had a wonderful session, though we came, we run late. Thanks for joining, and thanks for the appreciation.
Thank you so much. I'd like to thank all the speakers for making
Appreciate it.
session so insightful. Thank you so much, everybody.